So good evening, everyone, and welcome to our episode in our continued series on medical assistance in dying. And this evening we will hear a pastoral response by Dr. Eric Wasylenko. And Dr. Eric Wasylenko is a palliative care physician and clinical ethicist. He speaks widely on topics around care at the end of life and has supported education for pastoral volunteers for many years. So let us welcome Dr. Eric Wasylenko.
Thank you, Michael, and thank you for having me here. I understand and I've heard the great talks that you've received from Father Cristino and Bishop McGrattan, and really wonderful learning and lessons for all of us about the deep mysteries of the Catholic faith and how we respond as human beings in this really difficult time around medical assistance in dying. And I wanted to say at the start, I've had the real great fortune to work with and to be part of the teams that provide care to people at the end of life, and the pastoral volunteers that you are and that many of your colleagues are critically important people in the journey. And we'll talk a little bit about that as we get into notions of accompaniment for all end-of-life care, not just for people who may have requested medical assistance in dying. I'm going to just start with a little reflection from Lawrence Freeman, who is an OSB and wrote a book a number of years ago called A Short Span of Days. And it's a reflection for people, caregivers and patients and family members, for those who are dying. And he says that death's door, only one person can go through at a time. But it makes a great difference to know that on this side of the door, there is a loving presence to accompany you and to prepare you for the presence that welcomes you on the other side. That seems to me the real mission of the caregiver in this field, to be that loving presence as fully and as humanly as possible. And I think that quote really sums up much of the work that you do and that your colleagues do in service for others. I'm going to start showing a few slides, and I have to always start at the start of my presentations because of my university affiliations and other work, just a declaration of my conflicts of interest or positions. And I have no conflicts to declare. I do have academic affiliations with the University of Calgary, the University of Alberta, and have contractual affiliations with the Health Quality Council of Alberta and Alberta Health Services in end-of-life work, also in the program development for medical assistance in dying that's been generated in our province in Alberta. And I will speak about Alberta specifically, even though I know that some people that will see these series will be from other provinces and may or may not know what's actually happening within their own jurisdiction. I'm also an advisor to the National Vulnerable Persons Standard, which is an effort nationally for people to really put some teeth to the language of vulnerability and what we're meant to be addressing and thinking about for people who are uniquely vulnerable as they're thinking about the end of their lives and may contemplate or be convinced of the rightness of various modes of dying. I am speaking today on my own behalf and not on behalf of any of these organizations. So just moving on, I'll say I'm also here not to take a side or to convince you about any particular point of view, nor to debate the merits and pitfalls of the various laws and regulations that we now have in Canada and each provincial and territorial jurisdiction. But I do want to assist people that are pastoral volunteers and working with those at the end of life to navigate the new circumstances, the new conversations that you may be having with the patients and family members that you're helping along this journey. This is important work you do as Catholic pastoral volunteers and even non-Catholic pastoral volunteers, your colleagues who are doing this work out of service for their fellow man. It's really important that we understand in the new ways that the law has changed and that how that impacts the care that we provide and the way that we speak with our patients. So there's some key messages that I'd like to address today. I want to make sure that people are aware of the permissible actions within the law as you're doing this important pastoral work. We want to talk a little bit about what's changed and what hasn't changed in the law, because there's lots of misunderstanding out there about those specifics. I want to address some notions of withdrawing and withholding interventions. We often hear in the media the fact that we've been doing this end-of-life care and a euthanasia type approach for many, many years because of our withdrawal or withholding of particular medical interventions, the result being that a person dies. And I want to just make the distinction between that from a moral and legal point of view from what we're talking about with euthanasia or medical assistance in dying. Want to address the notion of supporting dignity, and you heard some very clear language from the bishop and from Father Cristino about what dignity is, and talk a little bit more about compassionate accompaniment. That is the important part of the work that you do. I'll reflect a little bit on Alberta's program for end-of-life care and medical assistance in dying without going into those mechanics in detail, because those things can be looked up on the internet very easily, and I'll show you how you can do that. I'll talk a little bit about some of the future issues that are being contemplated that might extend or restrict potentially, but most likely extend the eligibility criteria within our country. I'll talk a little bit about how I see the gifts that you bring playing out, and then also provide a few resources for you for further contemplation and study. So what's the genesis of this idea of palliative or end-of-life care? There's lots of terms being bandied about, and I'll talk about them a little bit. But really this notion of pall or pall is to cloak. So you're familiar with this notion. There's a picture there of some pallbearers, and that's how we often will think about this word, pall. But the derivative of that word, P-A-L-L, really is to cloak. And so the pallbearer carries the pall, which is the cloak that covers the body. We now have caskets, but many societies for years before did not have a box or a casket to carry a person in, but would carry a person on a slab and would cover over with this pall or with this cloak. So this, through the work of the palliative care founders, Dame Cicely Saunders, primarily in the late 40s and early 50s in Britain, starting the modern hospice palliative care movement, used that term to talk about this notion of covering or cloaking and helping to relieve the suffering symptoms that people would have as they approach the end of life. We now use it a little more broadly and think about the concept of really this enveloping care as we try to help people towards the time of their death, addressing their spiritual needs, their psychological and emotional needs, their physical needs, their relationship needs and issues in preparation for their death. And also to help reduce their suffering, but to serve their function in a way that they can be as strong and as good as they can be functionally so that they can meet the aims that they have in the limited ways they might as their illness advances. People have very, very strong sense of important aims before they die in the limited time they have left. And so when we help people relieve their suffering, it's not only a good to relieve suffering because suffering is noxious to the human condition, but it's also really important that we relieve suffering so that people have the energy and the mental capacity and the wherewithal to actually complete those important aims before they die. And some of those aims may be very simple conversations with people that they need to complete before death. They may be more complex tasks they have about managing their affairs or accomplishing some last wish or some other thing. But each of those are really important to the person. And so we want, through palliative care, to be able to address those bits of both suffering and function to help people address this really important time of their life. Palliative care really says also that they will not hurry death along and they will not hold it back, that it's really a mechanism to try to help people in their suffering. There's a current controversy in the country about how we actually language this. And lots of people say, well, palliative care, that it means such a bad thing now because people are associating it with the end of life. We talk lots about late life care as well. So as people are approaching this last stage or phase of their life, how we can care for them during that time when their goals are so different than they would have been before. End of life care, terminal care really talks about the very last stages of a person's life, but end-of-life care and palliative care now really embody a much broader sense. So we're saying in clinical practice that people who might have a terminal diagnosis or a diagnosis from which they may potentially die, but it's not certain that they would, should have the benefit of good palliation or palliative care right from the moment of diagnosis. Because if palliative care is really meant to relieve bad symptoms from treatment or from the illness, and if palliative care is really meant to help support people's function so that they can live as well as they can during that stage of their life, then we want to be starting good palliative care very early in a diagnosis, even in conjunction with good interventional care that might be influencing the course of disease. So someone may have the opportunity for curative care, or they may have the opportunity to actually have maintenance of their health condition without a cure, but without a really near-term death from the illness. And so palliative care and this philosophy of palliative care is really changing now to embody that notion that we start good symptom management, we start good addressing of psychological, emotional, spiritual, and physical needs and relationship needs right from the moment of diagnosis, and not just when a person is about to die. And that's really important. So I wanted to move on and talk a little bit about medicine's place. And one of my colleagues, Dr. Bev Smith from Ontario, had this really nice reference in one of her talks about an author called Timmermans, and attributes to Freud this notion: while questioning that death is inevitable, our modern sense and our ability or our way to actually push death back adds anguish to this sense of inevitability of death, because we can secure these little small victories all the time over illness. We keep pushing it back, and we're really, really good at that. And thankfully, we're good at that in science and in medicine. But it raises, because we keep thinking that there's one more cure or one more way to push disease back, that the insecurity of the finality of death, which we will all come to at some point, about this ultimate demise, that we've now become insecure about the notion of death. We don't have to think about it every day. It's not so present in our minds because we think we can be potentially mortal for a much longer time. When many societies previously would live and have that lived experience throughout their entire lives. So I often like to say it's really only been 2.5 generations that people have not been born at home or have died at home. And we've had this very good opportunity to actually help people, we think, medically, by creating hospital systems and having people somewhere else for those important events. But people tell us in national surveys that they would rather be at home, and they really want that. Now, that's not the perfect choice for everybody, but for many people, that is exactly what they desire. And so our modern healthcare systems are really trying hard to make sure that we have good palliative end-of-life care in all environments, including at people's homes, in long-term care facilities, in hospitals, and in hospices, so that people can have some choice about where they live, and we can, and as they're approaching death, and also that their supports, their family members and others can be supported in important ways also. So we now have this sense, or what I think is actually a need for many people, to have what I'd call human control over death. Is that an illusion? And is it really actually a conceited illusion that we have as human beings, saying we can actually push death back? And we often do that in medicine, and say as clinicians, nurses, and doctors and researchers, we're just getting really better at pushing out the boundaries. That's not always what people want. And in fact, people will live longer, and we celebrate the notion that the length of life for most people has advanced quite dramatically in our society. Many people will live with multiple illnesses and a lot of frailty for many years before they actually do die. And now there's creeping into the medical literature in really strong ways this idea that we might actually help people stay alive, but that may not be in their best interests, or they may not desire that kind of life. And it's actually, in some really high-tech environments, it's actually very hard to die or to become dead through medical treatment. So moving on, I wanted to just talk about this notion philosophically about how we die, and where I think the battleground really may be in this moral debate and society debate about euthanasia and medical assistance in dying. I think it really is between what I would call a moral or a Western fascination with autonomy. And we hear that in the media all the time, this idea of, I want my ability to control my own destiny, my own fate. I want control over my decisions. I want to control over my life. And now I want control over the way, the manner, the timing of my death as well. So that's on one side. And on the other side might be really what I'd call, I guess, a psychosociologic and spiritual narrative about experiencing and acquiescing to the full range of life's offering. So we have this arc of existence that's been given to us in our Catholic tradition as a grace from God, and our life as it starts and as it ends as just the physical embodiment of our souls and who we are. And the acceptance and acquiescence of all that life offers us, the good and the bad, is really the other notion, and why we might have, from a moral theologic point of view, this understanding that you've heard from Bishop McGrattan and from Father Christino about the duty, the moral imperative, and the spiritual imperative to actually honor life in all its dimensions. So I would turn then to this notion of respect for autonomy, and that's really the right language in sort of bioethics conversation. It's not autonomy itself, it's respect for it, and it really embodies this notion of choice for ourselves. And autonomous really talks about self-rule, from the derivative root of the word. But it does not exist, this notion of ourselves and our ability to control our fate and our destiny in some limited ways, in a vacuum. And the notion of relationality, that we exist and live as human beings in concert, in community, is an absolutely vital concept to remember. So I would say that the nature of self and the nature of being a human, by its very self, the existence of being human, invokes the idea of the other who is with us as we travel through this arc of life. And so I come to the idea of accompaniment in this end-of-life work that you do and that I do and that many others are. I wanted to read from Jean Vanier's book, Becoming Human, and many of you would know deeply of the work of Jean Vanier. So I've got a little bit, I'm skipping some quotes from through one of his chapters, but I'll just read it to you. For this discovery, people often need help from somebody who walks with them, an accompanier. One of the most important factors for inner liberation is how we are accompanied. We must ask ourselves, who is walking with me? Accompaniment is necessary at every stage of our lives, but particularly in moments of crisis when we feel lost, engulfed in grief, or in feelings of inadequacy. The accompanier is there to give support, to reassure, to confirm, and to open new doors. The accompanier is not there to judge us or to tell us what to do, but to reveal what is most beautiful and valuable in us, as well as to point towards the meaning of our inner pain. In this way, an accompanier helps us advance to greater freedom by helping us to be reconciled to our past and to accept ourselves as we are, with our gifts and our limits. He goes on to say, the word accompaniment, like the word companion, comes from the Latin words cum pane, which means with bread. It implies sharing together, eating together, nourishing each other, walking together. The one who accompanies is like a midwife, helping us come to life, to live more fully. But the accompanier receives life also, and as people open up to each other, a communion of hearts develops between them. They do not clutch on to each other, but give life to one another and call each other to greater freedom. And I think that's the core essence of the work that you're doing. We've medicalized suffering. This is just a picture of an ICU. It's just a stock picture, and just to remind us that we've got a lot of technology around us now as we're caring for people, trying in a beneficent way through the gifts that God's given us of intellect and science and advancement to keep people alive. And it's really good that we have these things for us. And so I say that we can do amazing things, but there are limits. Technically, there's social limits and there's moral limits to what we can do. So we've altered the way that people die and what people encounter in their lives as they approach death. And that's really important to remember. So people say in the common conversations throughout the country, why can't we stop suffering in medicine? Medicine was never meant to stop suffering. It can make a big difference for many people in the ways that they do suffering. But suffering is more than physical symptoms. It's about internal pain as well. And when we're frustrated as palliative care providers and teams, when we can't really seem to make an individual patient we're working with feel better and safer, more relaxed, comfortable, and prepared, we come to this notion, even though we've given them very exemplary palliative care and their physical symptoms may be primarily abated, that the internal symptom of suffering, of fear, of uncertainty about the future that people come to us with, medicine is not prepared actually and able to abate. And so that's often why people will come to you with the request, or to me with the request, to say, I want to think about these other ideas about how I may die, and what are the options or the opportunities I have in the mode that I want to die. And people have been asking, even well before the law changed, they've been expressing this idea or this need to be dead. But that doesn't always mean for the person that they're saying, but I want some action taken to cause me to become dead. But it's an expression of the suffering and the loss that they're experiencing as they advance in their illness towards this future where they will not be in physical existence any longer. All of us have questions about what will that be like, the process of becoming dead, and what will it be like after we're dead for our loved ones and for us. We just don't know that. It's one of the great mysteries of life. So when we medicalize suffering and the resolution of suffering, there could be a problem. So here's what society's asked us to do, because society recognizes that through the medical system, there probably would be the greatest chance to help abolish, if you could use that word, or minimize the suffering that people would have. When we can't do that relief of internal suffering, somebody, society says, should be given the authority to help a person to become dead. So the society asks us to provide relief, comfort, dignity, and support a person to their best functioning so that they can achieve their important aims. And that's really an encapsulation of the comment I said about what society asks palliative care to do. Newly now, they say, provide an option for an early demise. And with this option, do three things. Assure conscience rights of providers are harmonized, protect vulnerable persons, and make sure access is fair and reasonable. Those three things in concert, not one more important than the other. That's what society, through the laws of the land that we exist in, has asked us to be able to provide. So I wanted to create a distinction in our minds as well about this idea of withdrawing and withholding interventions. We talked right from the get-go about this idea that some people say, well, look, you physicians and nurses have been doing this for generations. You've been not providing CPR when someone says don't provide CPR, when you say you don't think you should do it. You've been stopping interventions. You stop the cancer chemotherapy, or you might stop an ICU intervention, so you withdraw someone from a ventilator. You might stop dialysis treatments, all those kinds of things, with the intent that the person's going to be dead because you're no longer intervening with their physical illness in the ways that you normally can. So what's the difference? The outcome's the same, as people might argue. Here's my response. Medical interventions are really interventions that are trials of therapy that interfere with the body processes that might be affected by illness. At some point, a patient says, in my values and the way I want to live, I no longer, thank you for all you've done, but I no longer want to have the benefits or the burdens, as it often is, of the treatments that you're providing for me. Or the clinician might say, we think that it's time to consider a different path because we can no longer do things that are unduly, or that would not cause undue burden to you. And we don't think that we can actually help you, as a person, your body, your physiology, in an effective way that meets your goals. So we should maybe start thinking about stopping this particular intervention. I always like to remind people, we never withdraw care. You'll hear physicians and nurses and yourselves maybe say this all the time, well, we're withdrawing care. That's not the case. We will always provide care. We're just withdrawing particular interventions with the goal, and with appropriate palliative care support so that the person doesn't suffer unduly, with the goal that it is now time to, as I had said earlier, acquiesce to what's happening to my body physiologically. So it is now time for my body to be allowed to die. and not to have this medical intervention that was an interruption of the process of natural death used any longer in service of my continued life, which was a laudable goal and the correct goal for the patient and for the team because they agreed to it before. So this, what I'd say, legitimate and carefully decided withdrawal. So it's not up to a physician or a team to say, we're going to just stop this. It's not up to a patient to say automatically, we're just going to stop this. It's a conversation, and that's a really important part of medical care now. That's very distinct legally and morally from the act of assisted death, which we call medical assistance in dying in Canada. Stephen Jenkinson wrote a terrific book called Die Wise, and in many, he was part of what he calls the death trade, the palliative care world for many years, as a pastoral guider and an emotional guide for many. And he's quite critical of what he'd call the death trade and palliative care, but it's a really important book as he tries to explore what it is about our society that's so worried about death, is so death-defying and afraid to have the conversation about death. And he thinks because of that fear of ours to have the conversations, we're reduced to two simple options. They're not simple in practice, but they're simple thinking-wise. One, that we have mastery over death. We control it. And the second, that we're a victim to death. And I would say that neither of those, and I think he might be arguing the same thing, but I'm not sure, but I would say that neither captures what I guess I'd describe as the art of this stage of life or the responsibility to continue to experience and grow through this difficult stage of life as well. So because, again, we've reduced the idea of dying to be either mastery over it, so I want to be able to declare the time and the nature and the way that I will die, as if we have that ability always to do it, or that I'm a victim to it. If I'm not allowed to do that, then I'm just a suffering victim to this experience of death. We've lost the importance of this in time of approach before death, both for ourselves as patients and for those around us who love us. So let's talk a little bit more about the new law. And I'm not going to go into details about what the law says and doesn't says, because you're probably well versed in that, and it's certainly available everywhere to read. I wanted to clarify that the court and the law did not grant a right to die. And you often see that headline in the newspapers. People have always had the right to die. It's a new notion of a person being declared by our society to be legally allowed to create the conditions or to do the act that will cause another person to become dead unnaturally. There is still a legal prohibition against counseling for, aiding, and abetting suicide in Canada. So the court and our new law only says for a certain designated kind of person that the law has defined, and a certain kind of health care provider who can administer a death-inducing substance, the law has changed. But outside of the bounds of that particular kind of person and that particular kind of clinician, there is still a criminal sanction against counseling for suicide or aiding and abetting suicide. So that's important to remember, and it's really important for you as pastoral volunteers because there are some considerations for how you can have conversations or not. I'll just revert now to a little bit of information about future considerations for the law, because the whole story has not been completed yet, and there will be lots of dramatic argument and debate within our culture and society about a number of things in the next couple of years. There's a lot of legal debate and moral and ethical debate on this notion of reasonably foreseeable death, which is one of the criteria in our law. There's some current court cases going on right now about that. People are asking, and the government's asking, should mature minors have access to this? And study is underway about that. People are asking, what impact might mental health conditions have on the eligibility for a certain person to have access to assisted death? Should mental health conditions have some special considerations or not? Currently, the law says particular things, and there's debate right now about what the law is saying about that. And thirdly, can people declare their wish in an advance request? So lots of people are really worried in our society about things like dementing illnesses, and they say, I would like to be able to declare now, while I have my faculties about me, how I want to be treated if at some certain time in the future, I'm no longer able to declare my wishes, and write that down and then have somebody be a proxy decision maker for me. And that's a very common request. So there's lots of study going on about the challenges around that, legal and moral challenges around that, and the practical challenges, as well as how that may or may not benefit some people. We're asking questions about, are there special considerations for organ and tissue transplant, both for the donor and the recipient, surrounding medical assistance in dying, and also are there special considerations for incarcerated persons? What are those special considerations addressing the unique vulnerability of somebody who's in an incarcerated environment? All those are things that will be discussed and debated and are currently being in many, many venues throughout the country. So I wanted to move on now to talk a little bit about Alberta's response specifically. We're continuing, first of all, it's important to say, to address the need for increased availability of palliative care in all settings. So lots of people have said, make sure that you have good access to palliative care for people before you're engaging in the conversations or a program around assisted death. Both things, we're hoping that palliative care will be advantaged in really new and important ways throughout the country. We have some excellent programs in Alberta already, and there's lots more that can be done and needs to be done. Beyond that, however, what we've tried to do is recognize that people come at this thought, this question in their own minds in very different ways. Some people will come to us and say, I've been thinking about this for a long time. They have a resolute desire. Now that the law is in place, they say, I know I want this. And others come and say, I really don't know what's right for me, but I need to explore it with you. And they might ask you that as a pastoral volunteer. They certainly ask me that as a physician. And you can feel this genuine desire to try to understand better what is the right thing for that individual person to choose. So, and then there's other ways that people will come at this as well. Some will come out of it out of real fear or a sense that they need to keep very private about this, and their family will try to convince them otherwise. So please don't tell my family member, but I want to engage you and ask you about it. Some will say, I just want to make sure that I'm eligible, so please provide the eligibility assessment so that I have in my back pocket this opportunity to access assisted death, even though I don't think I'm going to take that option. But they're worried about what their future suffering experience may be like, and they want to make sure they've kind of bounded their sense of future suffering. So I'm not saying good or bad about any of these choices and the way people are coming at this. I'm just offering sort of our perspective from our experience of how people might come to the start of a conversation. So if somebody expresses a desire or wish to die out of a sense of suffering, whether it's fear or physical suffering or emotional suffering or just a desire not to be alive any longer, we try to address what the motivations are for that person, why they've come to that particular decision in a non-judgmental way as well as we can in the healthcare environment. We also, so recognizing those stages of decision making helps us to do some really important programmatic things in the province so that we can have and you can have conversations if it's the right thing to do for your particular patient, the person that you're helping as they journey towards death. We also allow through this response for people to adhere to their moral commitments. And that's a very important societal conversation around faith-based and non-faith-based organizations who won't allow assisted death to occur on the grounds of their particular facilities, as well as the people who work within those environments. Alberta's response, I think importantly, has been also to provide what we call a care coordination service. And that small team of people doesn't provide assisted death, but they coordinate the eligibility assessments that are part of the legal compliance. They coordinate the actual assessments for particular vulnerabilities. So they're trained to really think about and look for situations where a person might be being coerced, or because of their inability to access, say, mental health care or palliative care or chronic disease management care, they're saying, I don't have any other options but to relieve my suffering in this way. They coordinate the clinicians and the supplies for provision of assisted death if that's the way that the patient has decided and if they're eligible. They make sure that there's a mechanism for transfer and location of the patient when that's necessary. And those people are accessed by either via a website or by calling HealthLink 811, which is a provincially available number that almost all people know about. I think it's accessed for all health services about 2 million times in the province of Alberta in a year. So people really know about it, and it's a way that the province has decided this will help there to be equitable access, so that people who might live in a more distant place where there aren't providers who are willing to provide assisted death could have access to the conversations, the eligibility assessments, etc. So all those, again, I'm trying to speak as neutrally as I can, those are the mechanisms by which our society in Alberta has decided people can be in compliance with the law, both the providers and the patients. They also work on reporting mechanisms and the evaluation of the experience as we go through this phase of the program. So I wanted to address then pastoral volunteers specifically. As part of a healthcare team, you're working with a patient who's exploring this option potentially, and many of your patients will trust you enough to ask you about this option. It's really important you remember that you have very limited legal protections, and the extent of that protection is not always certain. It's very nuanced depending on your participation with the team and what the patient's asking of you. So it's important to remember that as pastoral volunteers, you do not have legal protection if your conversations with the patient would ever be construed as being counseling a person for this form of suicide, or aiding them or abetting them in any way. So it's not your role, and it's not your legal role, forgetting about the moral role right now, to be giving access, providing access to the information for the patient. So what do you do? How might you respond? Your first response should really be one of openness and compassion to the suffering that the person, I think, is experiencing and expressing through this request for information of you. Also non-judgment. So when I'm often speaking with people, we sort of go through some of the actual language you might want to say if somebody asks you this question, because it comes at you in surprise. When I'm talking to medical students and physicians and nurses, I sort of relay these common scenarios that will suddenly hit you in the face as the medical provider, and you need to be prepared for that. Because a patient, when at the moment that they bare their soul to you and bring you into this very intimate circle of uncertainty and request and desire, need to know that you will respond in a really human, loving way to them. So if your first response is shock or hold back or put up a barrier or to stumble through the words, then they might interpret that as you're not a person that they can access for guidance about themselves as a person. So we always try to tell healthcare providers that having a response prepared and practiced, and I say to medical practitioners, develop your response, practice it in the mirror, practice it with colleagues, so that the first words out of your mouth, your body language, your eye contact, is one of openness and acceptance rather than one of judgment and holding back. And then you support what I call a therapeutic conversation. It can be anti-therapeutic or it can be therapeutic, and it needs to be one of non-judgment, regardless or irregardless of your particular moral stance on this issue. So the next action should be for you to suggest that the person talk with their physician. It is not your role to direct them onto the resources that there might be, or to guide them, or to make a call for them, or anything like that. So the best person to address their specific questions is their physician. It might be a nurse practitioner or another one of their nursing colleagues. And as a Catholic pastoral volunteer, I think it's very valid and important, depending on how you know this person and their own faith, that you suggest that a conversation with the person's priest or spiritual guide would be really valuable. So that again recognizes that a person is not a series of cells and organs. The personhood reflects their spirituality and their bigger being as a created being. And so addressing and recognizing that there is a spiritual component to this request and to this person and to their life is really important. So I wanted to turn really briefly to this idea of conscience protection. And you heard some lovely words from Father Cristino and from Bishop McGrattan about what conscience is and isn't. I'm not going to go into any detail around that, but in the sort of secular world, I talk about this a fair amount. There's this concept of objection for reasons of conscience is important in our society. And we had that, the first concepts of that we got from conscientious objection around going to war. When we talk about a person, though, and their own behavior and their attitudes around conscience, I think we need to change the language. So I don't want those who are opposed to and will not participate in assisted death to be called conscientious objectors. That labels them in some way as maybe a bit offside or maybe a bit bad. And it might be that we'll just take palliative care clinicians for an example. The majority of that group in Canada feels they would not want to participate in assisted death. And so I'm part of that community, and I'm also both personally, as from a human point of view, as a professional, from a physician point of view, and from my moral and theologic view, I'm opposed to assisted death. So I will not participate. That is not because I'm a conscientious objector. It's because I'm adhering to my moral commitments as a human being, as a physician, and as a companion of somebody who's approaching death. So it's a bit of language. I want to try to change the conversation a bit in our society around that idea. So I wanted to address then what this notion is of the pastoral mission of medicine. It really is informed, as I think Father Cristino has reminded us recently, of the intersection between virtue and ethics, and what we do in our professions, professing to do for another, even at risk of self-harm, or not worrying about our own particular needs around the caregiving. That's what we're actually doing when we're professing. I will commit to my patients in as deep a way as is humanly possible, and I'm professing so that they can trust that I will put their needs above my own and that I will be there for them. And that's really what we profess. And when that's supported by good virtue and appropriate moral and theologic ethics, then I think we come to this pastoral mission of medicine, where really we're here as professionals to make a difference for a person who is suffering and who is in need of that human and technological ability that we can provide them. So the key context for end-of-life caring really, in my view, is the provision of expert, dignified, human, compassionate, and loving care. And that is accomplished by everyone who surrounds a person who's experiencing an end-of-life journey. And it's just as important, the work you do, in providing, through your mission, the pastoral support and accompaniment, as is the work that I do, assessing and providing a medication for someone to relieve their particular suffering. It's really a profound human endeavor, this notion of healthcare provision, and we have to remember that. What do we bring as accompaniers? Well, there's this interdependence, as the quote from Jean Vanier talked about. We're giving and receiving in this idea when we accompany another person. We give the gift of ourselves. We give our skills. We give our biases and beliefs, and we need to acknowledge that we have those biases and beliefs. We give our own needs. We give the gift of our own past experiences that can inform the good work that you do. We give our own emotions and our suffering and our hopes as being persons with this other. And we give a commitment to our duties to this person who we're caring for and who's put their trust in us to guide and help them. So a few final thoughts. The gift of ourselves, both personal and professional, in journeying with a fellow person who's dying, for some people, is a way of following Christ's teaching and his example, to care for those who need that care. For others, it might reflect their own religious tradition, and that's fine. And it also might sort of reflect a sense of pastoral duty or gift that they're bringing as human beings. And for others, it can be, together with those things I've just mentioned, or solely, a gift of human compassion that's not part of a religious tradition, and it might be a manifestation simply of professional duty. One is not better or worse than the other, but together those things can be really powerful. But we always need to remember about this idea of humility. So a picture of Mother Teresa carrying this child, we recognize our place as mere interveners in the person's life journey. And there's fancy medicines to be given that can intervene, and there's loving, tender care, as you see in the picture, that can be as powerful and important. Now, my strong sense is that all of them together make the difference. One is not better or worse than the other. There's times that you need this, and there's time that you need a really fancy technology, and they're all valid and important. But we need to have that sense of humility, and I think having lost that is where we've come to in this sort of autonomous and scientifically driven society that says, we've got a technique to actually override a person's life, let's use it, when it wasn't really part of the natural course of the person's illness. So that's again this idea of the difference between when somebody had asked the question, and I think Father Cristino gave a beautiful response in the previous segment about that difference between providing a medication at the end of life that may actually help somebody become dead sooner when the intention wasn't that. It's very different. This notion of assisted death really is taking what's now a noxious substance, so it's a drug, but it's now a chemical that's meant to not heal or improve somebody's physiology and the organ function. It's now meant to completely override it because we're using such high doses that it actually stops the particular organs that are necessary for continuation of life. So even though the person is on a trajectory to death, they're not dying from their illness. And they're not dying even from the drugs that normally would be beneficially helpful for their palliative symptoms. They're dying from really an overdose of a very strong set of drugs that will override physiology. So that's why some of us would call it an unnatural means. I'm going to just provide you with a few resources now at the end. This website here, the ahs.ca/MAID website, has all the background information and the legal stuff and the resources for how people can have conversations with their patients. There's also a website there for the Vulnerable Person Standard, which is really an attempt, as I said earlier, to put some meat to the bones of this concept of vulnerability, how we can actually be pushed to make sure that we've addressed this. There is a very strong call for people in our society to say, because an autonomous agent who has agency, they've got their mind about them and they can decide for themselves what's right, declares that this is what they want, and if the laws say that this person is eligible, that's where the question needs to stop. But we need to be very reflective, deeply reflective, because of the importance of this particular act and the finality of the act. Have we made sure that we've addressed all notions of vulnerability this person might face? And if they had those things fixed, would they have not chosen assisted death? There's a few books that I've referred to today that are worth addressing. Stephen Jenkinson's book, Jean Vanier's book, I think is a beautiful reflection, and Lawrence Freeman's as well that I read a quote from. And Sister Nuala Kenny, who many of you would know, has recently written a book and published it called Rediscovering the Art of Dying. It's a very good sort of and short read about the notion of Christ's suffering and his passion and death and how that relates to our own experience as we approach death. I'm going to end there and thank you for your attention and happy to answer some questions. Yes?
What can I say or do if a patient asks me about medical assistance in dying, but also at the same time expresses fear that their family members should not learn about this request?
First of all, what might be the actual words that you feel comfortable you would say if a person says to you, I'm thinking, you've been ministering to me now for the last few weeks. as I'm journeying towards death. Say I'm in a hospice or I'm at home or in the hospital, and suddenly today I say to you, when I'm thinking about this medical assistance in dying, what might you say? Any thoughts?
I think you'd want to touch on what the fears are or the motivations, to have the conversation, go to that direction. Is it a shortcoming in the palliative care or pain management? Is it, some other concern about end of life, the journey they're about to take?
And addressing some of the reasons why someone came to this is a really important part of the overall assessment that the whole healthcare team does need to make. So a good point. Any other thoughts? First words out of your mouth.
I would be concerned to maybe venture into why a person doesn't want the family to know, see what's happening there.
So again, a very important thing, the healthcare team, and this is part of that notion of vulnerability. Is there something in the story of this patient that would make that request happen? And we're always guiding people, because in Alberta at least, the death certificate would say how the person actually was made to become dead, and the illnesses that led them to that as well. The family will end up knowing about the medical assistance in dying. So I would want to explore, without judging the patient or anything else or coercing them in some other way, I'd want to explore what is there about that need for privacy that's really important. And is there anything else that we might want to address during this time to potentially heal a fractured relationship? What would the experience of bereavement be like for that family member who wouldn't have known this was the mode of death and might be very uncomfortable about it, or who may have wanted to be able to support the person in some way, either acknowledging this was okay for them or that it wasn't okay for them, and how sort of that person is left to live the rest of their lives might be really important to the person. They hadn't thought about that issue. For many people who make that request, it really is out of a sense of fear that their family won't understand, or that they'll try to talk them into it or try to talk them out of it. And so helping sort of heal that bit of relational challenge, I think, is part of the job of palliative care. Now, the patient may not want that, and we need to acknowledge that, but at least we have to explore it. So just let's return a little bit to the very first words out of your mouth. Somebody asks you, even not the question about privacy, but I'm thinking about medical assistance in dying. What are the first, I want you to think about what are the words, the actual words, not the approach that you take. What would be the words you might use?
How do you feel about your contemplating this act? What are getting them in touch with their own feeling about it, or articulating how do they feel about it? What's the core feeling that's present?
Sure. So you're saying try to get into touch with how people might be feeling about this and get them to describe more. And some people would say, well, what brought you to this? And that might be a good way to do it as well. But really trying to understand what it is about the person and their desire. I always like to have people think about the idea of first saying thank you for trusting me enough to ask me about this, or to say something like, I understand this must be a really difficult conversation or thought for you. Can you tell me more? And both of those phrases, they come at it a different way, but they express an openness. They tell the person who's asking you about this, who's now declared some worry or concern or intention to you maybe, we don't know what it is yet, that you are open to some sort of a conversation, and that you're not judging them, and that you're there in a sort of a therapeutic accompanying manner that doesn't express your moral stance for or against assisted death. And that's a really important thing, especially as Catholic pastoral volunteers, to be careful about. You also can't get into the discussion too deeply as pastoral volunteers about sort of the advising, because again, you're not in a place to be actually giving that particular guidance or advice from a legal point of view, and maybe not from a moral point of view either. But just if you're the first person they've turned to, just what I would call a human Christ-like response would be one of enveloping in trusted concern, and that's okay. And so figure out some phrase that you feel comfortable with, that feels genuine to you, so that the patient feels that you're open to supporting them, not necessarily in this route or choice, because that's not your role, but as human beings asking for you as another human being to reflect on this concern or request or worry that they have. I think that's really important to remember. It can be, again, as I say, an anti-therapeutic moment where they feel pushed away, or you're uncertain or you're fearful, or it can be a very therapeutic moment where they know they can trust you with their deep inner feelings. And that goes back to the sense of Jean Vanier's accompaniment, that you're walking with a person in your own uncertainty, in your own fear, in your own sense of what's right and wrong. They also have those, and you're walking together with them. And there's a whole team around you as well to help with the expertise around those things in all the dimensions, the physical and the legal and the moral and the ethical, the spiritual, all those dimensions. People are there to help.
I just have a question. For medical doctors that are object to being part of this euthanasia, if they have a patient that comes to them wanting a referral to somebody else, maybe because they're not going to do it, how does the Alberta Health treat that? Are they obliged to refer them, or?
Thanks for the question. So the question was about a physician, and it would extend to nurse practitioner as well, or other healthcare providers, who does not believe that this is the right thing to do from a moral point of view and to participate. Are they obliged to actually refer the patient? It's a really vexing question, and some clinicians in the country have said that a referral or any other action that helps in any way to facilitate a patient obtaining medical assistance in dying is the same thing as doing it yourself. So they are as morally culpable. And that's a stance that some take. Probably not a huge number of people take that stance, but it all hinges on your definition of what a referral is. And so there's been some really challenging conversations legally and with regulators, et cetera, in the country about what the notion of a referral is and your involvement if you are referring someone. So for some, this notion of the care coordination service provides a bridge between the clinician who says, I will not facilitate your access, and not helping the patient to carry on with their end of life care and concerns. So if the patient is left to their own devices, because I, as somebody who is adhering to my moral commands, will not give the patient any inclusive information about the options that are available or how to access that without me referring them directly, then many people would say that might be actually falling below the standard of care and professional duty that you have. So I can't leave a patient to their own devices. In Alberta, what we've done is say the patient can access the 811 number and get access to the care coordination service, who can then work through all the issues. And that removes the responsibility of a physician to directly refer to somebody. Now, some people will say, I will refer to a clinician or a team who can, from a range of choices, deliberate on all the end-of-life care options that there are. And if it turns out that the decision by everybody is that medical assistance in dying is the right way to go, they can provide that. But it's not a slam dunk that they're going to provide that particular option. That, for many, is very different than referring directly to a person who, as their main and almost only option, will presume that assisted death, medical assistance in dying, is the route that's going to be taken. So there's a distance between I guess the directness of referring or making available access to various kinds of programs. So we think that's helped. And in our conversations with Covenant Health and with the bishops of the province in Western Canada, there is sort of an agreement, I think, that is the best we can do to make it acceptable enough for a person to continue to stay with their patient. So important for us when we're teaching medical students and other clinicians to say, if a patient makes a decision, it might not be what you think is right or might not be within the sort of the moral stance that you think is appropriate, but we don't want you to abandon your patient. We want that trusted relationship to be able to be maintained. So you need to, hopefully, through this mechanism of the care coordination service, who is distant from you and distracted sort of from your direct line of sight or referral of the patient for assisted death, that you can still support the patient in the trusted relationship that you had and can accompany and walk with the patient for all their other needs. Because as they're contemplating this option and going through the process that the law requires, they still have important physical and mental and emotional, spiritual and relationship needs that we can provide. So we want to make sure that we don't cause an administrative sort of set of rules to force the clinician to abandon their patient or absent themselves from that very important, trusted relationship at this key part of their life. Thanks very much for your attention, and best of wishes in your good care. Take care.